much. So as Juliana said, I'm a respiratory and general paediatrician, and I am a professor of medical professionalism at the Royal College of Surgeons and the Bon Secours health system. And before that, I spent 3 years at the State Claims Agency analysing clinical incidence, claims and costs, which culminated in some national report writing. So that is my background to patient safety. So the learning outcomes from today is that at the end of the webinar, the students should have a knowledge of the importance of making the correct diagnosis, a knowledge of how best to arrive at the correct diagnosis, a knowledge of the consequences of inaccurate diagnosis from a patient safety viewpoint nationally in Ireland, a knowledge of the importance of correct diagnosis regarding medical legal claims nationally in Ireland, a knowledge of open disclosure and its benefits, and a knowledge of the importance of professionalism in healthcare and patient safety. So if we first of all start off with the importance of making the correct diagnosis. Now, for the purposes of this talk, the term misdiagnosis will include both inaccurate or delayed diagnosis. So firstly, correct diagnosis. Obviously, it is very important to make a correct diagnosis, because then the appropriate investigations are recommended and are implemented. You want the appropriate treatment and management plan to be put in place. It's important to provide an accurate prognosis, to potentially reduce morbidity, to prevent delay in diagnosis, and to prevent unnecessary investigations, because that may lead to independent complications or may lead to a time delay. On the other hand, misdiagnosis, whether that's inaccurate or delayed or a failed diagnosis, leads to potentially incorrect investigations performed, potentially incorrect treatment, potentially incorrect management, potentially incorrect prognosis, possibly increased morbidity, and possibly increased mortality, and potentially medical legal claims for those reasons. So then, knowing the importance of the correct diagnosis, how do we best arrive at the correct diagnosis? And so what you need to do, obviously, for everyone needs to do a very thorough investigation and examination, but assuming that you are up to date regarding your knowledge, the guidelines and your competency skills, when you must always expect something unusual and be open to an unusual diagnosis. So consider an alternative diagnosis if something doesn't fit into a box, or if patient symptoms persist despite what you feel is appropriate treatment. Some people call it a rule of three, a little like baseball in the States: 3 strikes and you're out. So if a patient comes to you 3 times and you're not helping or you're not improving their symptoms, consider, should I be thinking of something else? If the patient is coming, then we think of the 3 R's. You need to review the history, medical notes and investigations again. Perhaps we've missed something. We need to rethink the case and consider an alternative diagnosis. And then thirdly, we need to refer to a colleague or someone who has an expertise in this area for a second opinion. So just to help with this, we will take a look at a medical legal case of misdiagnosis. And this is one that the Medical Protection Society shared. So there was a claim against a general practitioner or a family practitioner and some hospital specialists. The patient presented with recurrent diarrhea, a 4-month history of weight loss. The GP checked a stool culture and sensitivity. This was negative and prescribed codeine. Then he referred him, I beg your pardon there, he referred to gastroenterology services in the hospital where a sigmoidoscopy was undertaken and a diagnosis of irritable bowel syndrome was made. Now, 4 years later, the patient presented to the GP again with difficulty passing stool after the birth of her baby. The GP referred her to a colorectal surgeon, and again a repeat sigmoidoscopy was normal and pelvic floor exercises were recommended. 2 years subsequent to that, again she presented to the GP with a sensation of a lump in her rectum preventing defecation. Again, she was referred to the colorectal surgeons, a barium enema was normal, a colonoscopy was normal, and a pelvic ultrasound was normal. And again, back 3 months later with persistent symptoms of diarrhea and bloating, when a GP referred her again to the colorectal surgeon. It was at this juncture that a positive family history of pancreatic insufficiency was identified, and when she was tested, she was indeed pancreatic insufficient. So the patient made a claim against the GP and the specialist for failure to take into account her family history of chronic pancreatitis and pancreatic insufficiency, and failing to arrange a specialist referral and follow-up. Now, the expert opinions were sought by the Medical Protection Society, the MPS, and these were in support of the general practitioner and the specialist, because the patient had never mentioned her positive family history. So in this situation, the claim was subsequently discontinued. So the lessons that the Medical Protection Society want us to learn and that are highlighted are that repeated tenders, and she did repeatedly attend, with ongoing symptoms, consider an alternative diagnosis. Don't just consider them that they are an annoying patient. These are the patients we have to give extra time to and really give our attention to. Careful documentation of consultations is imperative and greatly assists when responding to complaints. So when the doctor gets a complaint, documentation is key. Repeated tenders consider all past consultations, particularly if the patient didn't see the same doctor or clinician each time. You want to review all of the notes and ensure that continuity of care is not impacted. And then significant, it's important to document family history in the notes and to update it from time to time. So next, if we moved on to inaccurate diagnosis and from a patient safety incident viewpoint. So I mentioned that I worked at the State Claims Agency, and during that time, myself and the team analysed 5 years of national data from public hospitals in Ireland on clinical incidents, medical legal claims and their costs. The first looked specifically at maternity and gynaecology services, and the second one, published in 2017, looked at national data on incident claims and costs. These are patient safety clinical incidents. So you may ask, what is the definition of an incident? An incident is an unplanned or unexpected occurrence which causes or has the potential to cause injury, ill health or damage. In Ireland, it's a statutory obligation to report all adverse incidents to the State Claims Agency on the National Incident Management System. And the National Incident Management System collates all this information. So an increase in incident reporting is reflective of a stronger patient safety culture. And in Ireland, the State Claims Agency is responsible for the clinical indemnity scheme that indemnifies all public healthcare professionals in public healthcare institutions. So here we looked at data from 2010 to 2014 inclusive, so this 5 years, and this is the most up-to-date data available. And the clinical incidents are in blue, and these increased by 6,521, which is an increase of about 16.2%. And again, that is a positive finding, indicative of a stronger patient safety culture. This increase may be because of changes in patterns of clinical incident reporting or a change in clinical care, or both. The red represents general incidents or non-clinical incidents, and they too had an increase. So then we looked at the incident rate, and you can see that the incident rate here has increased again over time, and it's 1,014 per 100,000 population. So again, that has increased, and that is positive. So while there were no incidents directly related to misdiagnosis, a delay or a failure to treat leading to an adverse outcome as an incident may be related to a misdiagnosis, i.e. an inaccurate diagnosis, a delay in diagnosis, or a failed diagnosis. So we're going to look at these because there wasn't a specific category on the National Incident Management System. And so if we look at the 10 most common clinical incidents reported over this 5-year period to the State Claims Agency, we can see that the most common one is other, where the incident doesn't fit into one of the offered categories. But delay or failure to treat comes in at 4.7% with 9,681. The other common incidents include medication, which in total, when combined, incorrect dose, missed medication, and incorrect medication admission accounted for 14.7 of the 10 most common incidents. But delay or failure to treat is up there in the top 10. So if we look at these incidents for medicine, we track them over time, and you can see that again in medicine, delay or failure to treat is a common incident and is in one of the top 10. We tracked 5 of these, and you can see that there's an increase over time from 2010 to 2014. So delay or failure to treat as an incident has increased over time. It accounted for about 7.9% or 5,477 incidents in the service of medicine over that time point, and that may be related to misdiagnosis. So what about inaccurate diagnosis regarding medical legal claims nationally in Ireland? And in this situation, we firstly look at the clinical claims over this time period in Ireland. And we can see that there's an increase from 447 in 2010 to 604 in 2014. This represents a 35% increase, which is quite high. And the majority were related to mass actions. For example, the Dupuy hip replacements in orthopedics or symphysiotomies. If we look at claim rate, again, the claim rate has increased and has gone from 10 to a peak of 17 per 100,000 population. That was when there was the peak of the mass actions, such as Dupuy hip replacement or symphysiotomies. And then in 2014, it is 13 claims per 100,000 population in Ireland. So what are the common clinical claims, and are they related to misdiagnosis? And here we see that yes, in position 3 and 4, 3 is failure to diagnose, where there were 227 claims, accounting for 7.4% of the total clinical claims over this 5-year period in Ireland. And delayed diagnosis accounted for 183 claims, which is 6% of the total claims over this 5-year period in Ireland. Other claims documented were unexpected complications following an operation or procedure, delay or failure to treat leading to an adverse outcome, unnecessary surgery, wrong operation, or unexpected complications during an operation or procedure. So what about the cost of this? Well, here we have a breakdown of the cost of clinical claims finalised over this 5-year period. It was broken down into awards or settlements to the plaintiff, legal fees to the State Claims Agency, legal fees for the plaintiff, other, which generally means expert reports, and then the total. If we look along the bottom, we can see that the number of claims annually between 2010 and 2014 has increased from 328 to 488. The total cost has increased from 49,963 to 69,204. However, when we take into account, when we look at the average cost per clinical claim finalised, including of compensation, settlement, legal fees to the plaintiff and legal to the State Claims Agency, the overall average cost has reduced from 152,000 to 141,000 in 2014. So if we look at that then, claims related to diagnosis, including delayed diagnosis and failure to diagnose, accounted for 410 claims, which was 19% of the 10 most common clinical claims. And misdiagnosis may lead to a delay in treatment with adverse events or adverse outcome, which accounted for a further 145 claims. Misdiagnosis may lead to wrong operation or procedure, which accounted for 105 claims, and or unnecessary procedure. So therefore we can see that misdiagnosis is very much related to clinical claims that we have seen nationally in Ireland in our public healthcare system. So let us look a little closer at the service of surgery. We picked surgery because surgery was the most common service in Ireland that had clinical claims created in it. And again, if we look at the number of clinical claims, there were 113 created in surgery in 2010. This increased to a peak of 414 in 2012, but a lot of them included the Dupuy hip mass actions, and then they reduced to 198 in 2014, but this is still a significant increase on 113 in 2010. So what are the most common clinical claims created in the service of surgery, not overall as we've just looked at? So again, delayed diagnosis is in the top 10 most common claims created in surgery during this time period. And this accounted for 50 claims and 4.5% of the total clinical claims in this service. Failure to diagnose accounted for 35 claims and 3.2% of the clinical claims created in surgery totally over this time period. So again, diagnosis is significant in surgery. We tracked the clinical claims over time, and you can see that delayed diagnosis in purple is essentially unchanged over time, and then the blue with failure to diagnose demonstrates a slight increase over time, but certainly we have been unable to eliminate these as causes of claims over time. So claims related to diagnosis, including delayed diagnosis and failure to diagnose, when taken together combined, accounted for 410 clinical claims and accounted for a total of 19% of the 10 most common clinical claims between 2010 and 2014 inclusive. And misdiagnosis may have led to delay or failure to treat, where there were 145 claims, and may have led to unnecessary surgery or operation, where we had 131 claims in this time period. We won't go through it, but there were similar results for medicine, for the service of medicine. Failure to diagnose led to 150 claims, and delayed diagnosis led to 95 claims. So in total, 245 claims in 2010, in 2014 inclusive, related to problems or misdiagnosis. So this is a real issue for all of us as healthcare professionals. So the Medical Protection Society give us another case to exemplify problems with diagnosis. And this is a common condition. A 33-year-old male attended a GP with a 6-month history of abdominal pain and rectal bleeding. The pain, he said, was relieved by laxatives, and there was bright red blood in the toilet and on the paper. He gave a history of straining at stool. There was no mucus and no family history of malignancy. And on examination, the abdomen was soft with slight lower abdominal tenderness, and rectal examination revealed no masses. For the GP, his working diagnosis was hemorrhoids secondary to constipation, and he asked the patient to return in 4 weeks for a repeat review if his symptoms persisted, and to get some blood tests taken for inflammatory bowel disease. However, the patient did not attend for bloods or for follow-up, and 1 year later was admitted to the hospital where metastatic colonic cancer was diagnosed, and he was dead within the year. Now, a claim was brought against the GP for diagnosing hemorrhoids when they were not visualized, and for resulting in a delay in diagnosis with a 9-month reduction in life expectancy. So the Medical Protection Society invited experts to review the case, and the expert witness agreed with the GP and said because the recorded history was so detailed that this was very helpful. Additionally, there was a safety net where the GP said, come back in 4 weeks if there's a problem and I'll review you. The other safety net was the investigations for inflammatory bowel disease. And hemorrhoids are frequently not visualized, so it was appropriate given the history of straining and fresh blood and that he had done a thorough examination to consider the diagnosis of hemorrhoids. An expert oncologist did not support the claims that the patient would have survived a further 9 months if the tumour had been diagnosed earlier. The Medical Protection Society denied a breach of duty and causation, and again the claim was discontinued in this case. The lessons to be learned for all of us. Record keeping, the Medical Protection Society said, was the most important aspect of defending this case. Important positive findings in the history and examination were documented, and relevant negative findings should always be documented, so that an expert looking at the case can see the clear logical reasoning that's being followed. A rectal examination should always be performed in patients with rectal bleeding, and clearly to document this if a patient declines the examination, and document that the patient is aware of the implication this may have on the diagnosis. Thirdly, although uncommon, rectal bleeding may be a cause of malignancy in young patient groups. So next we move on to professionalism in healthcare and links to patient safety. And here I just have a question for the audience. And before we start on professionalism in healthcare, I would like Juliana just to do a poll. And the poll is, do you have a professionalism in healthcare policies in your organisation? And a yes or no answer. Thank you.
Thank you so much, Dubhfeasa. The poll is now on participant screen, so you should be all able to choose one of the options, yes or no. And 40% of our participants have already done so. So the views are actually spread. So we do have two different set of groups. Just let's see what the final results are before we display them to the participants.
Sure.
So yeah, so we are ready now to display the results. Hopefully all those who wanted to vote did vote, and we have 70% of our participants reporting that they do have professionals and healthcare policy in their organization, and 30% saying that no, not yet. So over to you, Dubhfeasa.
Thank you for participating in that, because that's very interesting. A lot of these policies should be introduced and shared with healthcare professionals when commencing work, but it's no harm that these information will be provided or reminded to people on a regular basis, and perhaps those who feel they haven't, maybe they truly haven't, or maybe it hasn't been brought to their attention. So I think this is something that is coming to the fore a lot more and will be much more important. So that's good that 70% of the audience have one and are aware of it. So thank you for that. That's useful. So now we move on to professionalism and definitions of medical professionalism. There are many. Joe Shapiro, who is a world expert over in the Brigham in Harvard, would say it's about trust. It's trustworthy relationships. Michael Brennan in the Mayo Clinic in Rochester would say it is how we justify the trust of our patients, colleagues, and public to do the right thing in the right way, for the right reasons, and in a timely manner. Here at our university, at the Royal College of Surgeons of Ireland, a definition has been authored together with a group of world leaders in professionalism, and it says it's about values, behaviours and attitudes that promote professional relationships, public trust and patient safety. We should always aim for excellence and be leaders in our field, and that medical students and doctors should be committed to compassion, communication, integrity, honesty, advocacy, altruism, ethical practice, work in partnership and teams, reflective practice leading to continuous improvement, evidence-based practice, cultural sensitivity and be aware of self-care. And all of this culminating in the main aim, which is patient-centred service. Now, there are a lot of definitions internationally, but there's a lot of consistency in them. The American Board of Internal Medicine said professionalism, in redefining it, is really about accountability, and we need to replace autonomy with collaboration, authority with evidence, assertion with measurement, control with transparency, and self-interest with public interest. We no longer work alone, we work in multidisciplinary teams, and we need to be accountable. So what about the history of professionalism? Well, back in 1999, the ACGME said that professionalism had to be one of their key core competencies. Then in the same year, both the European and American groups came together to produce a medical professionalism project. A professionalism charter was produced in the USA in 2002. And in 2011, it became a legal requirement for doctors in Ireland to maintain professional competence. The 8th Guide to Professional Conduct and Ethics was published in 2016 by the Medical Council of Ireland. So who first looked at professionalism? Well, Paget of Paget's bone disease and Paget disease of the nipple of the breast looked at medical students back in the 1800s, and he tracked them for 10, 20 and 30 years, and he could show a link between unprofessional behaviour as students and unprofessional behaviour as a clinician. This work has been replicated, and it was shown that a lack of thoroughness and an inability to perceive their own weakness in the first 2 years of medical school was associated with unprofessional behaviour in clinical years. Other studies have shown that unprofessional behaviour in medical school is associated with disciplinary action as a practicing physician, and of concern, this may be sustained over decades. But the good news is that professionalism can be taught and modelled. So professionalism is about patient safety and patient-centred care. And in 1999, as you know, the first quality paper by the Institute of Medicine in the States to err as human identified that between 44 and 88,000 preventable deaths occurred per annum in the States. Communication was at the root of a lot of these. Subsequently, the Joint Commission published in the annual report that communication was identified as the root cause of more than 60% of all sentinel events reviewed over a 10-year period. Furthermore, the Joint Commission published that as part of a national survey, 51% of respondents saw disruptive behaviour correlate with compromise in patient safety, and 71% with compromises in quality of care. And it was on the back of that in 2008 that the Joint Commission published a sentinel event alert about behaviours that undermine a culture of safety, so disruptive behaviour. And that may be either passive or active. Passive, where one doesn't answer a bleep, or a healthcare professional will say that they'll do something but do not follow through. And more active could be shouting at someone or throwing an object. So what about teamwork? Teamwork is critically important. Everyone comes to work every day with patient centre at its core, and most of us work in multidisciplinary teams. There has been a shift from an individual to a team-based model over the last number of years. And it has been shown that surgeons that work less well as a team have higher risk for death and complications. Their patients have a higher risk for death and complications. In contrast to that, high-performing hospitals that put a lot of emphasis on teamwork and regular communication actually have a better mortality from acute MI or myocardial infarction. So there is an onus on the individual to participate in the team, and there's an onus on the organisation to promote professionalism, because organisational professional identity involves education and training in teamwork, human relations, and group dynamics. So are there drivers for professionalism? Yes, there are. There are a number of burning platforms from the patient, from the staff viewpoint, from the student viewpoint, from the healthcare system viewpoint. From the patient viewpoint, it would be patient safety and a positive patient experience. From the staff viewpoint, morale, recruitment and retention, prevention of second victim. From the student viewpoint, from student safety, and from the healthcare system viewpoint, from its reputation nationally and internationally, and potential claims. The risk of litigation and claims affects everyone. The patient, because something wrong generally has been done and they may suffer morbidity, the staff that may suffer a second victim, and the healthcare system from the reputational viewpoint. So what is professionalism practically in the hospital, and what does it mean to us? It means patient safety. It means clinician safety, because that encompasses self-care and prevention against clinical claims. It's the clinical working environment, training, risk management, quality improvement, open disclosure, patient-centred care and engagement, education, undergraduate and postgraduate, continuous professional development, research and clinical practice. These are all pillars of professionalism in healthcare. So like we said, the organisation must support professionalism, and there must be a behaviour of because the behaviour of the healthcare organisation impacts the behaviour of patients, of physician staff. The organisation must have a process in place to address the disruptive behaviour that we've already discussed that can lead to patient safety incidents. It should be a commitment to health and well-being of staff, and our leaders are responsible and accountable so that we have a top-down and a bottom-up approach. So next I wanted to touch on the second victim. And some of you may be au fait with the second victim. Do we have a question there, Juliana, on the second victim? Will we open the poll?
Yes, the poll is now open, so we'll get our participants to cast the vote now. So essentially the question that we would like to find the answer to, have you heard of the second victim concept before today? And obviously 2 options to choose from, yes and no. I'm sure those participants who attended our webinar on second victims were going to be in the yes group, but there are still a number of participants, as I can see, that haven't heard of the concept. So let's just wait a couple of more seconds before we display the final results.
Sure.
Okay, so now for those ones who can't see, 40% of our participants did hear about this concept, and 60% of our participants reported that they haven't heard that yet. So over to you, Dubhfeasa.
Okay, well, thank you very much for participating in that, because I have to say, up until a few years ago, I was with most of you and had not heard about the second victim. So in the picture here, you'll see Albert Wu, and he is the physician now working in Johns Hopkins who coined the term the second victim. And the second victim is really say, for instance, a physician, I'm responsible for causing harm to a patient. So supposing we take an example of me giving penicillin to a penicillin allergic patient. My patient may end up in the intensive care unit with anaphylaxis, so obviously they are the first victim, but I am the second victim because I feel so bad that I have inadvertently caused such harm to the patient. And this can result in physical symptoms in me and psychological symptoms. So I might have insomnia, I might be more anxious, it can lead to depression, lack of confidence. People who are suffering from the second victim are more inclined to have adverse events because they lack confidence. Some of them leave their work, and so it can really lead to a downhill spiral. And in putting up this picture, we remember our colleague, nurse Kim Hyatt, and Kim had worked for 25 years in a hospital, but unfortunately gave the incorrect dose of calcium to an unstable baby. And sadly, this unstable baby passed away. And it was her first error that had been documented in 25 years, but Kim committed suicide. And this is not unheard of. So the second victim is very real, and we need to protect our clinicians and our healthcare professionals, as well as our patients, and professionalism encompasses this. And so Albert Wu started the Resilience in Stressful Events. He started the RISE program, where there is a group of healthcare professionals that are available that you can phone, that you can meet with and discuss with after an adverse event occurs. And it's been shown that if you can talk to a colleague and discuss the problem, then that reduces the risk of the colleague, that reduces the risk of the healthcare professional developing symptoms of the second victim. So this is very real.
Thank you, Dubhfeasa. Can you just show your screen so we can you can resume showing? Thank you.
Is that okay? The picture is still on the screen now, Juliana.
Yes, it is perfect. Yes, just continue on. Thank you.
Okay. Now it isn't moving my cursor to the right.
Okay, so if you click into your PowerPoint to activate it.
Oh yes, sorry. Thank you, Juliana.
No problem.
Okay, right. So in order to ensure that you're practicing in a professional way, you yourself and me myself, we have to care for ourselves, and we have to be in a good place mentally and physical. So physician well-being and self-care is essential to professionalism. It's essential to effective, compassionate patient care. And so we need to be aware that certainly clinicians or physicians, that as a group, doctors are more inclined to depression, suicide, substance abuse, burnout, and that if we develop the second victim, it has an effect. So the impact of an error on us in some studies has shown that our relationships at home and at work can deteriorate in 30% of cases. So support is required. We need to reach out. And support can be offered either as group peer support or one-to-one, like I mentioned in Johns Hopkins with the RISE program, or with Jo Shapiro in the Brigham, where she has both a group support and one-to-one support. So doctors, it's been documented, suffer quite a significant amount of stress, but we're only moderately good at seeking support for that stress. So we'll move now from professionalism and its link to patient safety and clinician safety to open disclosure and its benefits. So open disclosure has been defined as an open, consistent approach to communicating with patients and their families when things go wrong in healthcare. It does include expressing regret for what has happened, keeping the patients informed, providing feedback on investigations, and providing feedback on the steps taken to prevent a recurrence of these adverse events. Principles include acknowledging that something's gone wrong and being truthful, timely, clarity of communication, and apologise that things have gone wrong, but that does not mean an admission of liability. Recognising that patients and carers' expectations, providing professional support, risk management and systems improvement, multidisciplinary responsibility, clinical governance, confidentiality and continuity of care. And over the last number of years, the State Claims Agency, in collaboration with the Health Service Executive, has been rolling out a national programme regarding open disclosure and going around nationally to all of the sites and the different hospitals and training in open disclosure. So just from our viewpoint here in Ireland, it was in 2007 that the Minister for Health established the Commission on Patient Safety and Quality Assurance. And the aim was to develop clear and practical recommendations which would ensure the safety of patients. Then in 2008, the report Building a Culture of Patient Safety was completed. The report was approved by the government in 2009, and the national programme, collaboratively between the HSE and the State Claims Agency, began in 2010, and a national policy launched by the then Minister for Health, James Riley, in 2013. And really, open disclosure is being implemented across the country over the last number of years. But why is open disclosure so important? Well, from a patient viewpoint, from an ethical viewpoint, from a frontline staff viewpoint, and a financial viewpoint, these are all reasons, but primarily it is the right thing to do. Over many years, patients have been asked, and it's well documented in the literature, that patients want to know when something goes wrong, as we all would as patients. 91% of patients want to prevent a recurrence, and 90% want an explanation in some of the older studies. They certainly want to know about a major and a moderate and a minor adverse event, but they're less interested in near misses. From an ethical viewpoint, we should be doing it. It is the right and correct thing to do, and we feel good about it. And from a frontline staff viewpoint, it's going to help prevent the second victim, because all of these events, as we've discussed about adverse events, can increase stress, increase relationship breakdown. One can feel unsupported, lack confidence, and sadly in some cases has led to suicides. But what about a financial and legal viewpoint? Well, a lot of work has been done, as you may know, in the University of Michigan health system in the States, where they moved away from a deny and defend policy and moved towards an early open disclosure and quick offer of compensation. And they showed that that they will be open and honest and offer quick compensation if a mistake has occurred, but they will vigorously defend any claim when the hospital and the clinicians and healthcare professionals are right, and they will view court as a last resort. So increasing the speed to resolution was key, in addition to the honesty and openness. And they have shown that this resulted in fewer claims, up to 36% reduction, fewer lawsuits, and a shorter time to resolution. And that time reduced from 1.36 to 0.95 years. So looking then, there was a sharp reduction in the rate of paid claims and either flat or declining levels of compensation payments and liability insurance in the States in the last 7 to 10 years. And this isn't all to do with open disclosure, but part of it was open disclosure and non-traditional reforms, including safe harbors or national guidelines, capping lawyers' fees, in addition to open disclosure. So today, in conclusion, I hope we've shown that an accurate diagnosis is important at all times and where possible. Remember the 3 R's if a patient's symptoms are not resolving and there's a repeat visit with the same symptoms despite the treatment that you feel is appropriate. Review the notes and investigations, rethink an alternative diagnosis, and refer to an expert colleague. An inaccurate diagnosis may lead to delay or failure to treat incidents, and these are amongst the 10 most common incidents reported in Ireland. Failure to diagnose and delayed diagnosis are common causes, 3rd and 4th place nationally in Ireland for common clinical claims between the years 2010 and 2014 inclusive, our most recent data. And professionalism in healthcare is intimately linked to patient safety, and it's related to patient safety and clinician safety because it incorporates self-care and protection against claims. And open disclosure, the right thing to do, being open and honest, is in place nationally.